All right, good morning, everyone. I'd like to get our subcommittee for corrections started. I'd like to welcome everyone for being here today. Madam Clerk, would you take the roll?
Chair O'Neill.
Present.
Representatives McKinney.
Here.
Morse.
Here.
Snyder.
Here.
Slaw.
Present.
Folin. Here. Leitner. Here. Mr. Chair.
Thank you, Madam Clerk. Representative Slaw moves to approve the minutes from the subcommittee meeting held February 29, 2024. Hearing no objections, the meeting minutes are adopted. Okay, everyone, just want to kind of preface this meeting by saying that there is $350 million appropriated in this current budget for prisoners' health care. And fiscal year 2025 budget, the department is requesting an additional $26.7 million for health care contracts and nursing staff. We understand there is a shortage of healthcare workers amongst the many other challenges facing the department when it comes to meeting the state's obligations to provide humane and adequate healthcare services to our prisoners. At this time, we would like to hear from our department today on prisoners' healthcare services, the effects of staffing shortage, and other challenges that we're going to talk about. So with that, I invite Mr. Kyle Comiskey, the Offenders of Success Administrator, Legislative Liaison, and Ms. Marty K. Sherritt, who is our Healthcare Administrator for the Department of Corrections, for their presentations. Welcome this morning.
Thank you very much, Mr. Chairman and members of the committee. As always, it's a pleasure to be in front of you. And as you mentioned, I'm joined by Marty K. Sherry, who is our Healthcare Administrator for the Michigan Department of Corrections. We have a short slide deck covering some of the topics that were raised by the chairman, as well as a few other topics that we think the committee should be aware of as we talk about the very important issue of healthcare. So with that, I'm going to turn it over to Marty K. to start, and then we'll be happy to take questions.
Good morning. To start, the department uses a mix of state employees and contractors. You just touched on that, to provide health care at each of our facilities. Each of our facilities has a health care clinic. We have both primary care and behavioral health at those clinics. Our health care costs are over $325 million, or just $10,000 per prisoner per year in the second bullet point. One of the things I wanted to emphasize is our prison population. While it has declined, the healthcare needs of the population are increasing. That can mean our off-site appointments, the general care, chronic care conditions of the prisoners will be increasing as their age increases, and we do talk about this later in the slide deck as well. One of the other things that we're experiencing too is we have over 11,400 prisoners that are on a mental health caseload compared to what we had a decade ago. If you think about those prisoners, about 10,000 of those are on an outpatient caseload. So that means they're typically they're seen monthly, and they're on a medication, a psychotropic medication. For our highest level of care, which is our inpatient, we have a little over 200, and that's at our Woodland Correctional Facility. And then we have some in-between levels of care, but that equates for a little over 30% of our population right now on that caseload. In terms of staffing, the healthcare staffing does remain a big challenge for the department. We have one of the positives that have happened in the last year is the approved enhanced pay for some of our healthcare positions, particularly on the nursing side. We do have to continue to use some contractors on the nursing side. What I would like to point out is that we are trending in the right direction. So when I was here last year, we had far more contractuals than we did civil service, and now we're starting to see a trend at every clinic, at least most of them, 50% are civil service employees. Some are trending to 100%. But, we still have gaps in certain areas, and we are still having to use contractual employees. We continue to do lots of recruitment, lots of fairs. We were recently at Lansing Community College trying to, provide information about what we do, opportunities in healthcare and behavioral health in the department. So that continues to be a focus But again, want to stress that we're kind of trending in the right direction.
So shifting gears a little bit to one of the kind of key commonalities within the populations that we work with is substance use disorder and the high frequency of individuals with relatively significant and persistent substance use disorder needs within our facilities. Oftentimes I think there's some confusion about, like, are people in prison for drug-related offenses? And the answer is oftentimes no, that most people are in prison for violent offenses or other non-assaultive offenses. But even though their criminal conviction might not tie directly to substance use, many still have an underlying substance use issue that needs to be addressed while they're incarcerated. What we have found is that roughly 60% of our current population has a recommendation to complete an outpatient level of substance use programming while they're with us. So we use a mix of contractors as well as state employees, again, to offer those two programs. We've made steady progress in terms of the delivery of those programs. During COVID, it was very challenging, obviously. We had significant limitations on our movement within the facilities, but we've rebounded in 2023 and continue to rebound in 2024, where right now the average ERDs, the minimum sentence of people who are in those programs, the median, I'm sorry, not the average, is January of 2025. So we're kind of back ahead in most cases, working with folks prior to even their parole consideration, which generally starts about 6 months before their actual ERD, since this might be a factor in the parole decision. The other thing that I think is really significant is that our substance use treatment services team has taken the step of expanding this programming to level 4. So historically, we were only able to offer this programming in levels 1 and 2 within our facilities, driven largely by resources and wait lists. But the decision was made kind of late last year to roll out starting this year to have those programs reach level 4. So that's reaching thousands of additional individuals who have these needs and reaching them sooner to work with them. And so we think that's a really important step. That is still rolling out. We're still adding additional resources, but we have level 4 prisoners that are starting in these programs or have started in these programs the last couple months. And so we think that's a significant step as we think about kind of our comprehensive approach to working with those with substance use disorder. Part of that SUD approach is obviously medication-assisted treatment, and I spoke last week to the committee about our plans for expansion in the current fiscal year. While we're not seeking additional funds for MAT in FY25, we are seeking to maintain the funding that was added in FY24 so we can do that expansion. As I mentioned, we currently have 10 facilities that kind of have what I would consider to be full MAT clinics, meaning they're doing both buprenorphine and naltrexone as options. So those are Gus Harrison, Carson City, Bellamy Creek, Ionia Correctional Facility, Cotton, Marquette, Macomb, Egler, Central, and WHV. They can prescribe either of those two treatment courses, and I think that's a key thing we need to make clear. This is always a prescribed medication. This is a medical professional making the determination about if somebody needs this treatment, and then if they need this treatment, what's the most appropriate form of the treatment for them to engage with. For our remaining sites that don't offer buprenorphine, they still have the ability to prescribe and provide naltrexone to those at those sites. As I mentioned last week, we have plans for expansion, kind of a rolling expansion this year with 3 sites that have been designated for expansion. So those are the St. Louis Correctional Facility, Muskegon Correctional Facility, and Hanlon Facility in Ionia. And then the Parnell Facility in Jackson is sort of on our radar as potentially a 4th site that could join towards the end of the year. Right now, we have about 900 patients who are actively utilizing MAT statewide. So it's a significant expansion from where we've been in the past, and yet we also recognize that it is not currently reaching everybody who might have this need as part of their treatment. One thing I want to stress, because I think this comes up oftentimes when we have these discussions about MAT, is that SUD treatment is multifaceted. It's not a single approach, or it's not the same approach for everybody who deals with substance use disorder. For different folks, there are going to be biological factors. Essentially, their brain chemistry has changed due to the use of narcotics and other drugs. There are psychological things. There are also socio-environmental things. One thing to keep in mind is many of the people in our criminal justice system are at a stage where they have very severe and persistent substance use disorder. So these are not casual users necessarily. There might be people that fall into that category in our system, but many of the people that we're working with have really utilized substances to the extent that it has changed their brain chemistry. And as a result, medication-assisted treatment is appropriate for some of those folks because we sort of need to reset some of those biological factors so then we can work on the counseling, we can work on the programming, et cetera. But if we don't have the tool in the toolbox for our medical professionals to utilize, we're going to struggle because no matter how many times they're in group, if their brain is telling them that they can't overcome those cravings or they can't overcome that, we're going to struggle to do that. And I spoke with our chief medical officer this week briefly just to kind of think about the best way to present this to the committee. And one thing she said is a comparison to those with diabetes. Diabetes for some can be controlled through diet and exercise, but it can't be controlled through diet and exercise for everybody. Some folks need to have insulin to properly control that. And same for SUD and MAT. So MAT is not for everybody who's used a substance who enters the MDOC, but it is for those who have that need at that level that the medical professionals think it's going to be part of their comprehensive care.
In 2023, we had 576 hepatitis C patients that were treated. The current cure rate is 98% to 99%, which is excellent. We have currently around 217 patients that are receiving treatment right now that haven't finished their regimen. We have another 140 patients that are waiting to receive treatment. So we're actually considerably down with what we had in terms of a backlog previously. The average cost of the treatment is $15,400, depending on, we kind of average that with the different medications. The treatment regimen is we either have an 8-week or a 12-week regimen, depending on which one is more clinically appropriate. The last bullet is the one I want to focus on. In terms of our numbers, we're in a really good place. I think what we're seeing is we're seeing an increased number of intakes coming into our system, so those coming in from the community that need treatment. This average the last 6 months have been right around 40 to 45 patients needing treatment. The previous 6 months before that, it was actually double that, so I think around 90 ish that were coming into the system. Our hope is really that they come in, receiving treatment in the community. There's federal Medicaid dollars for treatment. So really trying to work to make sure that treatment is happening before they come into the system. We do, in terms of our appropriation, monthly we plan for 45. That's kind of where our dollars are. So you can see with 140 on the waiting list, if we can keep that number, that would be great. It's just when it trends up, it becomes a little bit more difficult, and then there's a bit of a wait to receive the treatment. So just wanted to stress that.
So for the final section of the presentation, I'd like to talk about the aging prisoner population. And to be clear, this is not the only factor in what's driving our healthcare costs. As the chair mentioned, we have 2 requests in the FY25 budget related to healthcare. One are the contractual costs for our main contract. Those are essentially inflationary cost increases driven by things like an increase in the prisoner population, increase in staffing costs, an increase in certain healthcare service costs. And then the other request relates to our contracted nurses in terms of the cost of contracted nurses going up. So staffing costs are clearly a driver when it comes to healthcare. But the other driver that I think as policymakers you need to be very aware of is the trend that we're seeing when it comes to the prisoner population, particularly around age. Each person's unique, each person's health is unique, but as an aggregate group, those that are older are going to experience higher healthcare needs. And so that's something we have to be really sensitive to. In the last 2 years, the median prisoner age has increased just 2 years, from 37 to 39, although I think many people would still find it surprising that the median MDOC prisoner is 39 years old. They would likely think that they're younger than that. But we've seen that slight increase. But the more concerning thing is that the prisoners who are 50 plus years of age as a percentage of the population has increased from 17% to 27% in 13 years. That is a significant challenge. In fact, when you compare 2009 to 2022 and you look at the age cohorts and you look based on actual, whole numbers, real numbers, not percentages, every age cohort, 5-year age cohort under the age of 55 declined in real numbers. Not surprising. The prisoner population has declined significantly since 2009. So as that decline has happened, all of those age cohorts below 55 have declined. Every age cohort above 55 has increased, even as the prisoner population has declined significantly. So what's happening is there are certainly fewer people incarcerated in Michigan as compared to 2009, but all of the reduction is amongst younger prisoners. And it's not even that we held steady with our older age cohorts. Our older age cohorts actually increased. Some of them nearly doubled in that period of time. So I think that's a really significant issue for policymakers to keep in mind. Here is our current age distribution for those that are 50 plus. The other thing to keep in mind is that many people in the criminal justice system, because of lifestyle choices, behavioral health, substance use, et cetera, they're actually a little older than their chronological age from a health perspective. So that's why oftentimes we kind of use 50 as a dividing line, because 50 in prison might be closer to 55 or 60 in the community. But as you can see, we have about 33,000 prisoners right now, just under 33,000 prisoners. Almost 8,900 of them are 50 and above. And again, in some of these highest categories, kind of the 70 plus categories, many of these numbers have essentially doubled in the last 15 years. So those are the numbers, but what are the challenges that it presents? The reality is that as an agency, we're adjusting and making the moves that we need to make to safely house folks and provide them with the care that they need. But we're at a point now where we have 230 prisoners that utilize a permanent wheelchair in our system. We have over 500 that use a wheelchair for distance. That means they're not confined to a wheelchair, but anytime they have to, say, go from one building to another building, they have to be in a wheelchair with an aide assigned to push them there. That's a pretty significant impact on our operations. Even basic things like where we house folks and how many handicap accessible cells or wheelchair accessible cells we have become relevant. We've had to make physical plant changes at multiple facilities to allow and accommodate for this. Costs of care are unique to each prisoner, but again, older prisoners are more likely to have age-related conditions, cancer, Alzheimer's, dementia, et cetera. Those can be difficult conditions to manage in a prison setting. That creates a lot of need in terms of just activities of daily living and other factors that really weren't contemplated oftentimes when prisons were originally built, but that we've had to adjust and manage. To do that, we have increased our utilization of specialized housing for these populations. We opened a medically frail unit at the Thumb Correctional Facility in Lapeer. We've historically housed a number of medically frail and older prisoners at the Lakeland Correctional Facility in Coldwater and continue to do so. We also have an infirmary as well as our dialysis unit at the Woodland Correctional Facility in Whitmore Lake. And then finally, we have our Duane Waters Health Center in Jackson, which kind of serves as our in-system health center for those that have the highest medical needs, very, very similar to a hospital. So with that, we'd be happy to take any questions.
Thank you, Mr. Chair, and thank you, Kyle, for being here this morning. So it's my understanding that the current health care provider in WellPath or Grand Prairie, that there's an agreement that they're withdrawing and you have a new contractor to come in and take over that contract. Can you briefly talk a little bit about that transition and what the timeline is on that coming up?
Yeah, certainly. So, yep, it is correct that, so our current contractor is Grand Prairie WellPath. We have mutually made the decision that they are exiting the contract and Vital Core will be stepping in. They'll be taking the contract with the same terms, essentially the contract's being signed over to them. Vital Core has been in state now for the last couple weeks, visiting our facilities. They've started their HR processes to hire folks. So in a sense, the transition has started, but in terms of the actual transition of care, that will happen a little bit in the future. But the goal is for that transition to be completed by May 1st of this year. And then from May 1st forward, then Vital Core would be the MDOC's healthcare contract.
So I guess the meat of my question is going to be, because there are, subcontractors and ancillary providers that WellPath contracts with to do, business such as, lab services, other vendors, hospitals, whatever that may be. Those contracts that exist with them, the state of those subcontracts, are those being transferred over in this, as VitalCore is taking over? What is the state of the subcontracts with WellPath? Are those subcontractors going to receive full and final payment before May 1st? If there's not a transition to the included in the new contract?
We expect that VitalCore will continue to utilize most, but likely not all of the subcontractors. I think, though, that they're likely to continue using the in-state subcontractors that have previously been used by Grand Prairie, as well as previous MDOC healthcare contractors. So we would expect that many of them will continue to be those subcontracted providers, even under the new contract. The business relationship right now exists between Grand Prairie and those subcontractors. We're monitoring the issue of payment very closely, but ultimately it is incumbent on Grand Prairie to resolve those payment issues with any of their subcontractors. But again, the state is very well aware and monitoring that situation right now.
Thank you, and I just look forward to following up on that as the transition continues to ensure that all of the subcontractors that are providing services under WellPath are, made whole as this transition happens, especially if the new provider does not continue to use those services.
We will be happy to keep the committee up to date as we get closer to May 1st.
Thank you.
Yep.
Thanks for coming in again. This is related to the Hep C stuff, just because I'm not familiar with what Hep C really does to a person or anything. But I noticed that in here you've got 140 patients that are roughly waiting for treatment. Do they have to be segregated or anything? I mean, any part of that, it's just a process, and they're just in turn waiting to get that to happen?
So the way we prioritize them based on fibrosis stage. So those, with higher health conditions or higher risks, they're going to be the first priority. And then those with a lower fibrosis stage, then they're going to be. Now, they are still monitored. So someone that's hepatitis C patient is going to be part of our chronic care. So they're still going to be seen by a provider, and then they'll be rolled into treatment. So, and a lot of it is based on when they came into the system. So, that 140 is probably going to be individuals that are more recently in, and they're going to be the lower stages, but they would still be followed by a primary care until they receive that treatment.
Thank you, Mr. Chair. I'm going to go back to the issue on the healthcare, kind of along the lines with Rep. Snyder over there. So obviously we're going to have this transition, and I think I asked the director briefly to touch on it, on whether or not, how they chose the next vendor. Was there an RFP that went out for this process? Because I know I understand that it's kind of limited throughout the country, I guess, with who can handle a contract like this with the prisons. But was there an RFP, or was it just you guys found another vendor, or how'd that come about?
So the terms of the contract were established via an RFP process, with Grand Prairie WellPath being the winning bidder a few years ago. And so the terms of the contract were competitively bid, and they were selected based on best value to the state. As we continued through the contract, the determination was made mutually by Grand Prairie and the MDOC that we weren't going to continue that business relationship. So we engaged in discussions and found a partner in VitalCore who was willing to come in and take the contract with the current terms. So we did not conduct a new RFP. Instead, we had essentially what's called a novation, where Grand Prairie signed the contract over to VitalCore with our approval, and VitalCore will become the responsible party to the terms that were previously negotiated with Grand Prairie.
Now, have you done that in the past where you didn't do an RFP and just, and the only reason I'm asking is because obviously we know healthcare costs go up all the time, but you guys are also asking for significant dollars, in my mind, for healthcare costs when it didn't go through a normal process. And as, with most of the dollars for corrections coming out of general fund, I just want to make sure that the processes are followed and that the people of the state of Michigan are actually getting, the process is happening where you can vet all vendors and it's not just transferring over to the next guy because you knew him or something.
Yeah, so to be clear, the FY25 budget includes about $16 million for this contract. That $16 million has no relation to the switch in vendors. So that $16 million are agreed to costs that we negotiated and agreed to with Grand Prairie WellPath before any switch in vendors was completed. So we do need that money because it's contractually the cost that we've agreed to, but it doesn't relate to the switch in vendors. Essentially, Vital Core had, again, agreed to the terms that had previously been negotiated with Grand Prairie. So those costs would exist regardless. In terms of the question about an RFP, healthcare RFPs are extremely complex. They are time-consuming. And quite honestly, I think what we would find is that the costs that would be returned from an RFP in the current environment would be significantly higher than us maintaining the current contract terms that we have negotiated. So for us, what made the most sense was to continue with the current contract terms. This contract has an expiration, as all contracts do. As we approach that expiration, we'll make some decisions about if we're going to take allowable extension years or if we'll rebid at that point. But our focus really was about making sure we have continuity of care and continuity of approach so that the patients aren't negatively impacted. And we had this opportunity to do that without actually increasing our costs through an RFP process.
Majority Chair, Vice Chair McKinney.
Thank you, Chairman. Thank you, Marty and Kyle, for being here. Just have a few questions, really three. The first one in the presentation is around, the extreme substance abuse disorders that our prisoners are facing day to day. Can you touch on, how many overdoses there have been and how many overdose rescues you guys have done throughout the department and throughout the facilities?
Yeah, and we can provide more detailed numbers to the committee, but it's a daily challenge to prevent the introduction of drugs into our facilities, and we do see prisoners who are somehow able to obtain that and are using that in our facilities. We have seen a small number of fatal overdoses, but we do also see folks who are essentially in an altered state, and we have to react to that from both a custody and a medical perspective. So we do that. We have Narcan in all of our facilities. That's sort of one of our key responses. Anytime staff encounter a prisoner who seems to be having some kind of health episode, one of the first things they do is Narcan, whether it's drug-related or not. So it is a challenge, and like I said, I'm happy to provide some more detailed numbers to the committee.
Yeah, no, I appreciate that, Kyle. Love to look at the data. And have you noticed any trends upwards at like certain facilities versus others?
I do think that there are certain facilities that are maybe dealing with the challenge more directly, like where there are times where you'll see things, or what will sometimes happen, and what we have seen in the past is where something is introduced and we're not sure the source or exactly what it is, but we see people who have particularly adverse reactions to it. So whatever it is, and a lot of it is sort of synthetic drugs at this point, whatever it is causing a more severe reaction and creating greater risk for folks. So that's also part of what we have to do and continually do is try to educate the prisoner population about, these are oftentimes, one of the things we deal with are soaked papers. So people create some kind of, liquid with some kind of synthetic narcotic or drug in it. They soak pieces of paper in it, and then it looks like just a little strip of white paper, but people will ingest it to get a high. The reality is you don't know what's on that paper. And so that's one of the things from an education perspective is that folks need to be really careful about. We try to educate them on is that, you don't know what that is. And we've certainly seen times where people have had very adverse reactions to some of that.
Okay. My next question, I appreciate that. My next question is around healthcare workforce shortage. I mean, that's overall, the entire industry is going through that. And I'm sure our healthcare workers are getting pulled which way and whenever to come to this facility versus that one. What are the competitive wages the department is offering? Like, can you touch on that in terms of like the number and like benefits and things of that nature you guys are trying to do to, shorten those numbers?
Well, I do think the civil service, the 20%, what we're doing now over a period of 3 years is making it more competitive with the community, capped with the state benefits. So when I go out and talk to staff that have just been hired, that's been one of the things they've said is, and what we are seeing is our contractual staff are now transitioning over to civil service because of now those wages that were, that we've increased them, they're a bit more competitive with the contractors. I will say, all of community is, they're still utilizing contractors. I think one of the reasons why people like a contract is they like to do a short stint at like a company. We do get those individuals that, they go from place to place. We get retired nurses that come in the summer. We have a few that just want to be in Michigan for the summer and then they're contractual and then they go somewhere else. So there's not much I can do about that other than we have great, summers, so we get some. But I do think with the civil service increase, it's made it far more competitive with the financial and then the benefit package as well. So that's definitely improved things.
Thank you for that. And my final question would be around the medically frail. I think citizen guidelines, I was just talking to one of our chairs, Christine Morse, about it, and pretty much the older population is stemming from, citizen guidelines reform that we desperately need to do here in the legislature. And I know there were some policies that recently passed in recent years around the medically frail. I heard that it was so stringent that only one person got out, if that's correct.
Unfortunately, that is correct.
So can we, do you guys think this is something we need to really look at? And because these folks, we've traveled around, me and the chair, around these prisons, and, these people aren't endangered to society or to themselves, really. They need to be out. So, what are some things we need to do to try to, it's going to save you guys costs of the department too, but what are some things that we need to be looking at in terms of moving these people out, transitioning out, if that makes sense?
Yeah, absolutely. And you're right. So far under the statute that was adopted a few years ago, we've only been able to successfully parole one person as a medically frail parole. So I think as a state, we really need to return to that law. I do want to highlight that Senator Geis has Senate Bill 599 that I think is targeted at doing that. And I know that she has been working on that very diligently, and the MDOC and other stakeholders have been part of that conversation. But in terms of what's sort of not working with the current law, it is that the definition of medically frail is too stringent. So there's a couple key factors. One is that it requires the use of a validated risk needs assessment, but unfortunately those risk needs assessments are not developed to essentially discount for risk when somebody is medically frail. So it thinks of them as being able-bodied, and really doesn't even factor in age all that much. It factors in age a little bit, but not all that much. And so it's sort of looking at them as what's their risk at sort of their most, vibrant self, and it's not thinking about the fact that what's their risk when they're largely bedbound. And so we think that needs to come out. The other thing that we've identified is that the current law has sort of two prongs. One deals with conditions such as dementia or Alzheimer's that impact activities of daily living. The other prong is kind of serious or complex or persistent physical health issues, but it limits it to those that cannot stand, sit, or walk without assistance. The cases we see often are folks who have a terminal diagnosis, like a terminal cancer diagnosis. The reality is they can do those things, stand, sit, walk, without assistance, until very late in their illness progression. But this is a parole process. There's hearings that have to be involved. Victims have to have their right to be heard. And so if we wait to the point where somebody's at a stage where they can't get out of bed, we essentially can't get them through the process fast enough for them to parole. And so the Senator Geis bill includes a new provision that folks that have a terminal diagnosis and an expected life expectancy of less than 12 months, that we could start that process for them and parole them if they're eligible. The final thing in that bill that I think is relevant, and we continue to work with other stakeholders on, is the law right now indicates that folks have to go to a medical facility, essentially a nursing home. That adds a layer of complexity because we have to locate a site that's willing to work with them. And sometimes, even though they're very medically frail, that's not actually really the appropriate level of care for them to receive, particularly if they're end of life. The appropriate level of care is essentially hospice, and it might be hospice at home. And so the last thing that the bill does is it opens up that possibility for home placement. And as I said, we're still working with some stakeholders on exactly how that would work to address some potential concerns with that. But I think what's really key to remember is that the Pro Board is making these decisions 6,000 or 7,000 times a year and knows how to manage risk, knows the tools to manage risk, knows how to, support appropriate placements for folks. And so we'd like to see that extended to this population as well, so that they don't necessarily have to go to a medical facility. If it's appropriate for care, then that's where they absolutely will go. But if they don't need to go there, we should have some other options. So we're hopeful that the legislature will work on this. This is one of the MDOC's top 2 legislative priorities for the current session. It's not going to fully resolve the aging prisoner population. There are people who are not eligible under medically frail for other reasons, and we're not suggesting to change that. There are, some significant issues that, we recognize in some of these cases that don't make people a good candidate, but we'd at least like to have that mechanism for some of these cases to move them from the correctional setting to a safe community setting for that last stage of their lives.
Thank you.
Thank you, Chair. I'll just note the other piece to that could save us some general fund money is the proposal this year to obtain the waiver to provide people who are getting out within 90 days Medicaid, and then if the medically frail can be moved out, then they can be put on Medicaid, and we can save those very expensive costs if we're able to get them on the Medicaid program. So just a comment. But my question is about the substance use disorder, moving back to that. So here in your presentation, it says 60% of the prisoner population has a recommendation to complete an SUD program. What is that number? Do you know?
That would be somewhere around 20,000.
20,000.
Actually, it's probably even a little north of that, 21 or 22,000.
Okay. And we have here around 900 in the medication-assisted treatment. I know that's not for everyone, but if we were to move more people, if we had the funding for that, do you know what that number would be for MAT? An estimate?
Yeah, it's probably a little over 2,000.
Around
So we're probably a little less than half of what the total need would be. We would express a little caution that there's MAT, but MAT also requires staffing and operational changes, so that's why we're trying to take it as sort of a gradual ramp up. But we acknowledge at some point we'll need to reach a point where essentially I would expect every facility will need to be able to offer the different medication types.
Okay, understood. So my other question is, have there been any discussions with HHS about the opioid settlement dollars, and could those be used? Could some of that be used for the MDOC? I mean, I know in order to use those dollars, it has to be added program, so it cannot be something that you're already doing. But is there potential for that? Can you speak to if there have been any discussions about that?
Yeah, we've definitely been engaged in those broader discussions. The key thing when we think about those opioid settlement dollars from the MDOC perspective is that those settlement dollars are meant in part to offset the damage done by those companies' practices, essentially to unnecessarily introduce those drugs and medications into our system. The reality is the criminal justice system, not just at the state level, at the county and community level as well, has felt the brunt of the opioid epidemic. So we would certainly hope that as those funds are, allocated in the future, that their impact on those that are in the criminal justice system is not forgotten. I don't know that we've seen anything concrete yet, have we?
Yeah, we do have dollars.
Okay, I'll let Marty Kay talk about the dollars we have received so far.
So we have a little over $2 million in opioid settlement dollars. Additionally, I am the representative on the opioid task force that DHHS has, and their pillars focus on criminal justice. So we're really involved in that piece and then taking those recommendations moving forward. So it could look like more in the future, but that's what it is this year.
Well, I'm really happy to hear that you're very engaged in that, and appreciate that service. And maybe we could connect at some point on your work there too. Thank you.
Morris, thank you. That was very, very poignant. We've been talking a lot about opioid settlement and making sure resources go where they should go, particularly in our communities, in your committee. So thank you for that. We have some more. Okay, Timmy. Rep. McKinney?
Let me see. Well, hold on, one more. Could you explain, Kyle, why there's only like one recipient rights specialist for the total population for those with mental illness? I'm hearing we've been meeting with some folks around that, and so I'm hearing that's a big issue. Are you guys looking to do anything to help beef that up and provide more specialists, or can you touch on some of that?
So we're in compliance with the mental health code, which requires us to have a recipient rights person, and we do have that. The reality is we have mental health staff at essentially, well, most of our facilities at varying levels. There's some level of coverage at every facility, but some are not designated for certain caseloads, is probably the best way to say it. And so if folks have specific concerns about recipient rights, they can work through that office, and they can work more broadly through our mental health team. But we are in compliance with what we need to provide there, and be happy to continue the conversation with you offline if there are more specific concerns.
Thank you, Kyle.
Yep.
Just to follow up on the opioid settlement money, Mary Kay, where does that $2 million show up in our budget?
So we have an interagency agreement with DHHS. So that's how it's through there. So it would be from there. So it comes over and there's an interagency. Does that answer the question? Transfer. Yeah. Thank you. Yeah. And yep, through an interdepartmental agreement. So we have a couple different grants for them. So we have the opioid dollars, and then we have some SOAR funding that does peer recovery coaches in the community. So we have two different agreements with them, and then those dollars transfer over.
So that's in our DHS budget.
It should be, I would assume.
Yeah. Right? Matt?
Well, I will say that in the opioid dollars, it's not specifically laid out, but we did request in the boilerplate for 24 a report that would cite specifically where all the money is spent. We just didn't get that for 23, but for 24, we will be getting it. There wasn't a 23 report required. We did require one for 24. I don't know what the date is off the top of my head, but obviously we asked for it so we understand what's happening as we are doing the budget process for 25. So we should be getting it in time. I just don't know what the date is off the top of my head.
Thank you, Rev. Morris. Thank you. Rev. Slaw.
So, different subject, jumping off. Kyle, you and I had chatted just for a minute beforehand, but this is related to the report to the legislature that's due under PA 119 out of 2023. It's about community reentry programs, and supposedly it also includes electronic monitoring and a special alternative to incarceration. And we got a report this week in my inbox, shows that there were we've closed the community reentry stuff except for one place, and it just says it's open. It doesn't give any details. There's nothing in there. So from a reporting perspective, there's not much value to it. So I guess, are we going to see reports for electronic monitoring for alternatives to the incarceration? Is that something that's coming? Should we expect that? Is there, and if we're, I mean, the one is in Eaton, the reentry program is in Eaton, that's open. Is there any details about that? Because there's nothing in the report that would identify that it's even existing, right? So,
yeah.
Helps.
Yeah. So, so that boilerplate section has 3 different programs that it requires reporting on. We report them as 3 separate documents. We've only released the community programs one so far, but the other 2 will be coming. So special alternative incarceration and electronic monitoring. Those will be inbound to the subcommittee very shortly. And those tend to have more information than the community one. The community one, as you pointed out, most of those sites that were kind of covered by this when the boilerplate was created don't exist anymore. The one site that exists, although it doesn't even really fit really with the intent of the boilerplate, is the Eaton Intensive Detention Reentry Program. Despite its name, essentially what that is are laced jail beds where we place parole violators for short stays as sort of a timeout. So it's not a programmatic setting necessarily. It's really a public safety and sort of a reset setting, which is why we don't provide a lot of information about it, because it really is just a opportunity for us to get folks off the street. In many counties, that just happens in the local county jail. But in some counties, we don't have regular access to county jails for a variety of reasons. And so that's why we have that a little bit of extra contracted capacity in Eaton County that we can use to place folks. But yes, the other two subjects should be coming to the subcommittee shortly.
Chair, can I follow up on that?
Yes, sir, go ahead.
So if I were to follow up on that, and the very last line of the report that we got said you'd recommend that we have a discussion about, is this valuable? Obviously, if all we're doing is saying that it's open, that probably isn't very valuable. So I would agree with that synopsis. So what do we need to do to try and fix this, in your opinion?
So I think this is a section that needs to be reviewed. And actually, we met with the chairman already once this year on boilerplate, and this was actually a section that came up for discussion. So of the three things that we're reporting on, the community programs really, we would argue, should be eliminated, because the boilerplate is meant to cover a type of program that doesn't exist anymore, so we think it's sort of run its course, and that piece of the boilerplate should disappear. The electronic monitoring report, when you get it, you'll realize that actually all of the tables in that electronic monitoring report are also contained in the annual statistical report that we produce. So we would argue that that piece should also be eliminated, because you'll have that information through another source. We're essentially giving you the same tables twice in two different reports. The final piece is the special alternative incarceration. We would recommend that that report remain, because that is a unique report to that program. Although I think all of the things that are laid out in the boilerplate, some of them don't fit particularly well with the character of that program. So we'd suggest some continued dialogue with the subcommittee about making sure we're providing you with the information as a subcommittee that you need to understand how that special alternative incarceration program is running.
Sir. Kyle and Marty K., thank you for your presentation. Obviously, this is a very, very important topic, and we probably can talk for more than what we have. But, colleagues, I just want to indicate, if there's some topics of interest, please email me as we wind down in our process to get ready for our budget, to let me know, and we'll bring those up to talk about. But thank you all for being here, and seeing no absent members, there's no objection there for adoption. So this concludes our committee.